given a very short topic, and I feel it's good to be short and sweet. Let's try. I was not able to get my video on today because I'm still at work, so I just have my iPad so that I can scribble, and we'll try to learn to get something new together. Fine. So today the topic given to me is we're going to talk about head and neck cancers, right? We'll have about head and neck cancers. What I'll be talking is about laryngeal cancer, tumors in the nasopharynx, and a little bit about head and neck squamous cell carcinomas in general. And then there'll be one more class by my senior Dr. Ilan, who will be talking about salivary gland neoplasms, right? These are the two main things. Head and neck cancers as such in microscopy, I'm not going to have much of a variation because you guys know that the entire oral cavity, your nasopharynx, larynx, pharynx, everything is lined by the same epithelium, which is squamous epithelium. So obviously the majority cancers I'm going to get is squamous cell carcinoma. Okay. So we have to study about the evolution of head and neck cancers. All right. The first thing is about head and neck cancers. What is the world going to look about head and neck cancers? What is the world moving towards? When you take head and neck cancers along, like let's say 25 years back, the predominant of the head and neck cancers were the etiology was blamed on tobacco usage as well as your alcohol usage, right? Carcinogens, especially chemical carcinogens, especially. So over the period of years, what has happened is there has been a drastic change from chemical carcinogens towards our viral carcinogenesis, right? Organisms, viral carcinogenesis, especially HPV. I'm just talking about head and neck, in general, squamous cell carcinoma of head and neck. When we go to nasopharyngeal carcinoma, I'll be talking about one more virus as well as that's going to be EBV, right? So it's going to be HPV and EBV. These are the main two focuses majorly shift towards viral oncogenesis. Two reasons. One, why I'm going towards a viral oncogenesis and compared to an chemical carcinogenesis is when I know an etiology, the use of pathology is that I'm going to understand about an etiology. When I understand about an etiology, if it's viral etiology, I can try to prevent it. HPV-induced cancers. If everything is proven to be related to HPV, and if a person is going to get vaccinated to HPV, that's automatically going to come back again, right? We can easily prevent the cancers. That's what is the entire goal of any doctor, right? To prevent or treat the cancer. So the major update came in the recent WHO, and whenever we are going to report of late any head and neck cancers, we're going to report them as HPV-related and non-HPV associated. I'm sure you must have known that the new edition of Robbins has come, and they have also included that. So obviously it's required for you to remember about it. I'm just going to go in general about squamous cell carcinomas of head and neck. The major thing is going to be, the major difference is HPV-associated squamous cell carcinomas and non-HPV-associated squamous cell carcinomas. This is a major thing. Even now, when we report an biopsy for any head and neck squamous cell carcinoma, the oncologist, the head and neck oncologist still asks us to report whether it's HPV-related or not, because they are also going to, there'll be maybe minor change in treatment response or recurrence rate. Everything matters because of that. So an oncologist knows, a pathologist knows, an undergraduate should know, because yes, it has a treatment implication. First, we'll start with age. And HPV-associated carcinoma is seen in more younger individuals. A non-HPV-associated carcinoma is seen in older individuals. See, I'm sure you know that HPV is a sexually transmitted disease. So obviously people who are sexually active are going to be more exposed to the virus. And obviously it will be in much younger individual. Non-HPV is a routine chemical carcinogenesis, alcohol or tobacco induced. It's going to take a lot of time for a tobacco smoke to cause cancer. So obviously it'll be in older individuals, right? And obviously the risk factor is going to be the sexual practice. I'm sure most of you would have, the first thing you must have done in your second year of MBBS is to go through a forensic medicine. Yeah, all unnatural sexual practices may increase the risk of HPV-related oral cancers, right? And here, major culprit is tobacco and alcohol. See, this, I can never prevent it. You can have many Mukesh's in movie theaters. It's never going to get prevented, right? So here, when I'm going to look at the of HPV-related cancer, that also may change. So the location of HPV-related cancer is mainly in the oropharyngeal region. Non-HPV-related cancer, oral cavity, lips, buccal mucosa, and all. Because when a person smokes, more of deposit is going to be in these regions only. Not in other regions, little bit less. Fine. Presentation of an HPV-related cancer, there'll be generally a small lesion, but with nodal metastasis. They'll have a much earlier nodal metastasis, but generally the lesion is going to be smaller lesions. Smaller lesions with nodal metastasis. So when I have a smaller lesion, it's easier to miss. Okay, it's easier to miss. But nodal mets will be there. It will not be going to distant organs. Just the local regional nodal metastasis will be there. Because of infection, any infection is going to automatically go to a node, right? So here you'll have a larger primary lesion, large ulceroproliferative lesion. Okay, you'll have a large ulceroproliferative lesion. Distant mets is less common in an HPV-related cancer and is a bit more common in non-HPV-related cancer. Fine. And when you come to the histological subtype, microscopy is our main concern. I'm sure in the last class we saw about lung carcinoma, the microscopy. What did I say about the microscopy when we are discussing about squamous cell carcinoma? I told you to remember one pattern. The pattern is called as, I told that every squamous cell carcinoma will have the same pattern. The pattern was, if you remember them, that is your keratin pearl, right? Keratin pearl is the pattern for every squamous cell carcinoma. So this also will have the same keratin pearl. But when it's a non-HPV related cancer, I'm going to have non-keratinizing squamous cell carcinoma. And here, majorly will be keratinizing squamous cell carcinoma. Okay. Then I'm going to go to prognosis wise. One is going to be a viral etiology, other one is going to be a chemical carcinogen. Obviously, a viral etiology cancer will have a better prognosis because if I'm going to take care of proper precautions, I may not have the disease at all. So prognosis wise is going to be will have a better prognosis. This will have a poor prognosis. So this contradicts with the grading, contradicts with the microscopy. Generally, when it's going to be keratinizing low grade, it's what we say. But here, because of my etiology, I'm going to have a different prognosis. So first one we know is, we are just started with how HPV-related cancer and non-HPV-related cancer will differ clinically, pathologically, as microscopically, as well as the prognosis-wise. The next most important question is, why and how HPV causes cancer? Non-HPV-related, we know everything is going to be chemical carcinogens. You'll have mutation and it will cause cancer. The question is, why and how HPV causes cancer? I'm sure you must have read this in your neoplasia chapter under chemical viral carcinogenesis. I'm just going to give an overview brief about the same, how HPV and how and why HPV-related HPV infection can predispose to cancer. When you have a HPV genome, we have two different types. I'm sure you must have read about this as well. 6 and 11 subtype and other things. HPV, we have 16, 18 and different subtypes. 6 and 11, if you've gone through your gynecology postings, the warts, these are generally benign lesion. Normal warts, genital warts, these are generally benign lesion. I'll also tell why it's a benign lesion as well. When in 16, 17 subtypes, they are more in favor of malignancy. And our vaccines we have for HPV-related cancer, Gardasil, Cervarix, are more concentrated on my malignant subtypes. So when I have these two, these are all viruses. All viruses are obligate intracellular organisms, right? They live and they can survive only inside a cell. So if you remember your microbiology, you must have read about HIV genome a lot. HIV virus comes into my body. The genome gets integrated into my human genome and starts producing viral proteins, and it's going to reorganize HIV, and the HIV goes out and infects the other cells. This is the normal.
Class.
This is the normal way of any virus being acting on a human body, right? So when I have HPV, when I have two types of HPV, the malignant subtype HPV will integrate into a human genome, right? It's going to integrate completely into a human genome. Whereas the benign subtype of HPV, the HPV 6 and 11, will not integrate into a human genome. It will be in an episomal form. The benign subtypes is going to be in an episomal form. This is the reason why some of the subtypes can cause cancer, some of the subtypes can cause only benign warts. So what does episomal means? Epi is above, some is chromosome. Episomal forms is not going to integrate into it, but it's going to be somewhere in the cell and indirectly going to influence it. But here, it's going to integrate into the genome. Let's consider about malignancy, though. That's what our concern is. Let's assume this is a human genome, the blue color. And let's assume we have a red color HPV genome. So what happens is, this is going to, when it's going to integrate, it's going to integrate like this. I have the blue one and the red one also comes and binds along. It will integrate somewhere in between. So I'll have the blue one as well, the human genome. So when this is going to replicate, when the cell replicates or the cell protein sensing apparatus functions, it's going to synthesize viral proteins. The important viral proteins which we are concerned here is E6 and E7 protein. So these are the viral proteins which will be produced whenever any cell is going to divide and it's going to give out viral proteins as well. So these viral proteins are the ones which are going to be carcinogenic. What these viral proteins do is, the E6 viral protein will indirectly inhibit P53. E7 viral proteins will indirectly inhibit retinoblastoma gene. I'm sure you must have read about these two, right? Again, in oncology chapter, neoplasia chapter, I hope it's over, right? Neoplasia chapter. In the neoplasia chapter, you must have read about P53, which controls the cell cycle as such. It's a tumor suppressor gene. So when the P53 is gone, my tumor suppressor effect is gone. So I'm going to have more mutations, more cell divisions. Same with retinoblastoma. Retinoblastoma actually acts on my G1S cell cycle checkpoint. It's like a watchman. It's going to stop the cells to move from one G1 to S phase. So when the watchman is not there, any cell which comes to G1 will automatically go into S phase, which is cell division. S phase is a synthetic phase, and it's going to go to G2 and it will divide. So I'm going to have an uncontrolled proliferation because of these two genome, because of these two viral protein. There'll be an uncontrolled proliferation, which results in a cancer. That's how multiplication starts. That's how cancer is being produced in relation to HPV. It's not only in oral cancer, it's the same pathogens as cervical cancer, same pathogens as penile cancer, as well as your anogenital cancers. Wherever HPV is going to act, it acts in the same way. So I need to say that, okay, this person has HPV, right? I need to say this person has HPV because I told that HPV-related cancer has a different prognosis and non-HPV-related cancer has a different prognosis. So how do I say that this person is having an HPV infection? Or I have to say that this person is having HPV-related cancer. It's because of HPV, I should say. One clue is the non-keratinizing variant, but that's not always true. It's just more commonly seen in non-keratinizing, but I have to have some proof to say, yes, this is related to HPV. We're going to have different ways. There could be microscopic clues. I'm writing for MX for microscopy. I can have microscopic clues to say, yes, this patient is having, or this cancer is having an HPV-related infection. I can have IHC. I'm sure in the last class also saw IHC stands for immunohistochemistry. Can any one of you try and say the IHC for squamous cell carcinoma of lung? We saw about the IHC of squamous cell carcinoma. If you can remember, do let me know. And also I can have perfect P40 and P63. Amazing. And also I can have genetic proof. It's a virus, right? Any virus, the genome, I can put it up like HIV, you can diagnose it genetically. Using PCR, you can amplify the viral product. Why HIV? COVID. You're using the same thing, right? I'm just amplifying the viral product and I'm saying, yes, this patient has the genome. So microscopy, apart from the non-keratinizing variant, that's there still. What I'm going to say is, I need to prove that HPV is present here. HPV is a virus. If you remember microbiology, any viruses you read, they'll have one characteristic finding. Okay, if I'm going to say this patient is having a rabies virus, what finding if I say under microscopy, I'll say, yes, this patient is rabies virus. I'm sure you guys know that. Negri bodies, perfect. Right? When I say Negri bodies, I'm going to say, yes, this patient could have had a virus. In other words, whenever I'm talking about viral infection, I'm going to think of an inclusion body. Owl's eye inclusion, cytomegalovirus. Warthin-Finkelday giant cell, measles virus, right? Your pox virus, you have box cords, many inclusion bodies are there. So I need to see an inclusion body. So this virus also will produce an inclusion body. I'm going to see how it is going to look, and we're going to name it as well, right? So when I say HPV virus, I need an inclusion body. So let's assume this is a normal cell. I'm just drawing a normal cell. I'm using pink color for the cytoplasm because cytoplasm of squamous cell will be pink in color. And this cell has been infected by HPV. So HPV proteins will be produced, HPV viral particles will be produced. That's going to cause an abnormality in my nucleus, in my cell. So cell will be the same. My nucleus will go to this corner. I will have a pink color. Don't draw this pink color. I am going to make a change in the pink color. In this pink color, I'm going to have a clear inclusion in the cytoplasm. I'm going to have a very clear inclusion in the cytoplasm. This is the inclusion body here. I'm going to have an intracytoplasmic clear inclusions. See, I have to name this. There's a clear inclusion. It's all about imagination. For the guy who first saw this, it looked like a cave inside a cell, right? It looked like a cave inside a cell. Cell means site, erythrocyte, thrombocyte, megakaryocyte. Site means cell. Cave means coilo. So this is called as an coilocytosis. It looked like a cave, so it's called an coilocyte. So when any report says coilocyte, I'm not saying it's a cancer. I'm just saying it's an HPV infection, that's all. So wart also will have coilocyte. Cervical smear can also have coilocyte. Doesn't mean it's a cancer. For it to call a cancer, I should have the same thing. Dysplasia, invasion, keratin pulse. That's must. There's an evidence to say, yes, this patient is having an HPV. Okay. Next, a surrogate evidence of IHC marker. I'm not going to the squamous marker, which Ashwati said it's P40 and P3. That's the same marker. I'm going to go for a marker which says HPV is present, right? I'm going to use a surrogate marker. I'm not going to demonstrate HPV as such. I'm going to use a marker called as P16. P16 is a surrogate marker for HPV. This is must. Without this, reports don't go these days. If the oncologist wants this, I'm going to give the report. Even if the oncologist doesn't want, my duty is to say to the oncologist, yes, this is how it is. And they can take the decision based on that. The surrogate marker of HPV infection. Okay. You can use the same thing if you're going to write about cervical cancer. Everything means the same. Here, genetic testing, just PCR will detect me the copies of the virus, right? Same like a COVID, the copies of virus can be detected. The viral genome can be detected by the PCR. Okay. I'm sure you know about the PCR. You must have been taught a lot about PCR. See, one piece of advice for PCR. When we were in undergraduate time, we have never shown a PCR. We don't know how a PCR works. We've just read about PCR. That's all. My thesis in JIBMA was in PCR. That's the first time I saw a PCR. PCR will look the size of your tiffin box. That's all. You guys are smart. You must have Googled it. Then I went into PG. I thought that PCR will be the size of a fridge. I was looking all over. And the PhD in JIBMA said that, see, that's on the table in the corner. There are 5 PCRs. They'll be just in the size of a tiffin box. PCR is nothing but a box which can control temperature. Nothing else PCR does, right? So PCR will be very, very tiny. Okay. Next. So we saw about HPV. We saw about squamous cell carcinoma of head and neck. And we saw about how HPV will cause squamous cell carcinoma of the head and neck, right? So then we'll go to nasopharynx. So nasopharynx, what all can happen in nasopharynx? Have you been to your ENT posting? Has the ENT posting started, or you have been ever to ENT posting? No? Okay, great. So in nasopharynx, we are going to divide nasopharynx into few tumors are very common in nasopharynx. One, obviously, squamous cell carcinoma. I'm not going to repeat that. Whatever we saw about squamous cell carcinoma holds good for every squamous cell carcinoma in the entire oral cavity and also genital system. Fine. So nasopharynx, there are few tumors which are concerned for me. The first one is Nasopharyngeal Angiofibroma. When you go to ENT, or if you have read ENT, you must have read about this called as JNA. Juvenile Nasopharyngeal Angiofibroma. Juvenile is just for the age group. And otherwise, it's just Nasopharyngeal Angiofibroma. Second one, in nose, I'm going to have a tumor called as papilloma, sinonasal papilloma. Okay, we have sinonasal papilloma. This can happen in nose. Okay, we can have in the nasal cavity from the cribriform fossa. I can have a neuroblastoma because the cribriform fossa, the olfactory neurons will be there, and olfactory neuroblastoma can come from that. Okay, you can have an olfactory neuroblastoma. Olfactory neuroblastoma is also called as esthesioneuroblastoma. Both mean the same, doesn't matter at all. It's also called as an esthesioneuroblastoma. I'm writing NB for neuroblastoma. That's the other name for olfactory neuroblastoma. And obviously, we'll have your nasopharyngeal carcinoma. There's one more thing which is also mentioned apart from these 4 tumors in your organs called as nut midline carcinoma, which is a very rare tumor. For an undergraduate level, nut carcinomas may not go into it. I'll just give a passing mention when we go to the nut midline carcinoma. Fine. So first we'll go to these 3 ones. And obviously your giant one is your nasopharyngeal carcinoma. That also we will see. First one is about Juvenile Nasopharyngeal Angiofibroma, JNA. As the name says, age group is sorted, juvenile, right? Nasopharyngeal angiofibroma. When you go to ENT, if you are lucky, you may see these patients. Wherever in your ENT exam, if the word torrential epistaxis is there, which means the patient will have epistaxis, which will never ever stop, will keep on bleeding. You will have tumblers of blood coming out of the nose, not just nose prick, spontaneously, or even after a prick. When your history says it's torrential epistaxis, that's my concern. It's like plenty, too much. A torrential epistaxis, I'm going to think of a juvenile nasopharyngeal angiofibroma. It's benign or malignant? Benign or malignant? Juvenile nasopharyngeal angiofibroma. Just make a guess. I'm sure you guys know it. Benign or malignant? It has to be benign, right? It has to be benign, right? Because I don't have fibrosarcoma. If it's a mesenchymal tissue, only when I have the term sarcoma, I'm going to be worried it's malignant. It's a benign tumor. But one problem is this has too much of blood. Whenever something has too much of blood, it has to be a locally aggressive tumor. It can erode the bone. It will start in the nose, nasopharynx, it can easily erode the bone. It can erode the sinuses, it can spread everywhere. Whenever any tumor is vascular, take it as a dictum, it will be locally aggressive. When you come to bone, you will read a tumor called as giant cell tumor, locally aggressive because it's very, very vascular. Anything when it's very, very vascular, angiofibroma, it's a benign tumor, but the most important thing is it's locally aggressive, very aggressive. Okay, it's mostly a clinical diagnosis. Biopsy is not done for the simple reason, if you do a biopsy, the patient is going to bleed a lot. Already the patient is going to bleed. Why should I again go and poke it? Clinical diagnosis, take a CT scan of paranasal sinus. It will tell you the extent and we are going to treat. We'll see how to treat. Before that, we have to know about the pathogenesis. Pathogenesis is the most important thing for us. Till previously, it was said that a nasopharyngeal the etiology. Whenever we don't know the etiology, we are very fancy and we have funny name. We call it idiopathic. The literal meaning of idiopathic is we are still idiots about the pathogenesis, right? We don't know about the pathogenesis. So now, of late, everything is going genetics, and these guys also wanted to explore into genetics of juvenile nasopharyngeal angiofibroma and see what happens there. So when they saw the genetics of juvenile nasopharyngeal angiofibroma, they saw a mutation in a protein called as beta-catenin. I'm sure you must have heard about this protein, especially in your colonic tumor. DASH and beta-catenin act synergistically. There's one more gene. That gene and beta-catenin act synergistically. I'm sure you know that gene as well. It is seen in colon cancer. Starts with A. Not heard? Okay. There's a gene called as APC. Adenomatous polyposis coli and beta-catenin act synergistically. We'll see how they act and we'll see why that mutation is going to cause a cancer forming. So we have to see about normal first. We have to know normal. Only then we can know abnormality. In a normal resting cell, what will happen? That's the first thing we are going to see. Next, in a normal dividing cell, what will happen? Then we'll know what will happen when there's a mutation. We have to know normal, only then we can know abnormality. Fine. You are very early in your medical time. If you want to excel in medicine, please read physiology, and your physiology should be very, very strong. Pathology and medicine is after that. If you don't know physiology, you can never do medicine perfectly. Since you're in second year, if your physiology is not strong, please go and read back your physiology whenever you read pathology. Fine. So normal resting cell, let's take this as a cell. The cell, I'm going to call it a resting cell because it doesn't have a growth factor. It's not growing, right? And I have a receptor here, your G protein couple receptor, your 7 membrane domains, right? There's no growth factor here. I'm writing GF for growth factor. No growth factor. So what happens is, the almond shape one which I'm writing is APC. And I'm going to write this guy as well. This guy is beta catenin. The red dot is beta catenin. This guy is APC. Now, resting cell, APC or adenomatous polyposis coli, APC stands for that. Adenomatous polyposis coli. This APC binds beta catenin and is going to make it inactive. It's like your mom taking care of you, not letting you do anything, right? So what will happen in a dividing cell? Dividing cell, the mom is not there, or in other words, GF comes inside, right? Figuratively and here as well. When there's a growth factor, coming inside, this growth factor is going to act on the receptor. It binds to the receptor. Whenever any growth factor binds to a receptor, it's going to activate the transcription pathway, right? That's how anything acts. So the transcription pathway or the signal transduction, what it does is, when the growth factor binds, it's going to destroy APC. That's the main thing. It destroys APC. When it destroys APC, my beta catenin guy is going to be free. The beta catenin is free. When beta catenin becomes free, beta catenin goes in, signals to your nucleus, you go and divide. You have to divide. It promotes cell division, right? It's going to promote cell division. That's how in a normal dividing cell it happens. But you know that once division is done with, growth factor will disappear, beta catenin will come again with APC, so the division stops. That's how it happens. Whenever I have a growth factor, it will divide. After that growth factor goes away, the cell becomes normal, right? This is normal. Now what's going to happen is, I'm going to have a tumor. So I know that only one thing, every division is based on only one person, which is beta catenin. So when I'm going to have a tumor, or when I'm going to have a mutation in beta catenin, what will happen is, this mutation will not let APC bind to beta catenin. Both are bind normally. Because of this mutation, APC and beta catenin will not bind to each other, are separate. The most important thing, even without the presence of my growth factor, I don't want a growth factor. Even in the absence of growth factor, these are going to be separate. When they are separate, beta catenin knows only one thing: it's going to cause uncontrolled cell division. When I have an uncontrolled cell division, it will result in a cancer, right? That's how beta catenin acts. I need a gene for it. If you can remember this gene, do remember. The gene which encodes beta catenin is CTNNB1. Right? CTNNB1 is a gene which encodes beta catenin. That's how juvenile nasopharyngeal angiofibroma is formed. The pathogenesis. So it's a mutation, right? If you know any gene, let's take P53. A gene can be mutated sporadically, or you can get the mutation from your parents, inherited. Both is possible. So this is also a gene. This gene also can get mutated sporadically, or in other words, they can be syndromic as well. Juvenile nasopharyngeal angiofibroma could be, I'm not saying always, they could be a part of familial adenomatous polyposis, FAP syndrome. Right? They could be a part of FAP syndrome. See, I want you to remember this forever. When you're going to see a patient, previously when we are going to see a patient of JNE, we don't bother much, treat the patient and go away. Now, if you're going to see a patient of a JNA, I want you to have in mind that it could be syndromic, not always, rarely only, but still I want you to evaluate, take a family history, proper family history. If it is syndromic, pick it up very early and make sure the patient will not have a colon cancer in future. Do something regards it. Only when you're going to look for it, you will get. What your brain doesn't know, your eyes doesn't see. You have to know that JNA can be syndromic. If you know that, you will ask for a history. Let's say you become an ENT surgeon and you're seeing 100 cases of JNA. All 100 will be sporadic only. Maybe you see 1,000 cases, one can be syndromic, but it's worthwhile saving that one person, right? That's what we are reading all these informations for. So we know the pathogenesis, we know the age group, etiology, pathogenesis we know, and how it's going to look in microscopy. As the name says, angiofibroma, right? Angiofibroma. So I'm going to have blood vessels and I'm going to have background fibroblast. What do fibroblasts synthesize? What do they secrete? Fibroblasts secrete a substance. What is the substance called as? What do fibroblasts secrete? Fibroblasts secrete collagen, right? Fibroblasts secrete collagen. So I'm going to have fibroblasts which secretes collagen in a dense collagenous stroma. Fine. And I'm going to have very, very small blood vessels. Now you are going to say how the blood vessel will look. Say I'm having a collagen. Collagen is strong or weak? Collagen is strong. Blood vessel is flimsy. So the blood vessel will be plump, rounded, or will the blood vessel become slit-like? Perfect. This blood vessel will become slit-like. Because since collagen is very, very strong, I'm going to have entire tumor filled with collagen, right? These are going to be collagen. And I'll have here and there, I'll have fibroblast. I'm drawing the blue color for the nucleus and the fibroblast. And obviously, my blood vessel will become narrow. It'll be like a slit. It'll be like a slit. Will be like a slit. Okay. Now let's look at the history. When you go to ENT, you will have this history for sure. Massive torrential epistaxis is what I told first, which will stop automatically. It will bleed for like 2-3 cups, it will bleed. After that, you need not intervene, it will stop. The reason it will stop is, it's very narrow. The collagen will compress them. Once it compresses, bleeding will stop. History is based on the pathogenesis. It's based on microscopy only, right? This is how angiofibroma looks. Biopsy is contraindicated. You should not do a biopsy because that also will aggravate the bleeding. So how did we study the microscopies? Post-surgery. So you're going to tell me the treatment as well. Generally, surgery is not done. We're going to see the treatment as well. Surgery is done, but before that, I have to do one more thing. The entire tumor is a vascular tumor. So I need to reduce the vascularity. In what all ways you can reduce vascularity to a tumor? I'm having a tumor full of vessels, fully vascular, full of blood. I need to reduce the blood because when I do a surgery, I need not have bleeding. Too much bleeding I don't want. So what do? How do I reduce blood supply to any organ? Ashwati, it's a good thing VGF inhibitor, but it's very, very expensive. Vasoconstrictor is short acting. Anything else? Good thought process. Anything else? Anything else? I want to destroy the entire vessel. Thromboembolization, great. Not thromboembolization, we're going to call it embolization. There's a planned embolization. Platelet activation, I cannot do it only in that area, right? So what I'm going to do is, I have to treat this patient. It's a tumor. I have to remove the tumor for sure. But when I do remove the tumor, it's going to bleed a lot. So before that, what I do is, you're going to pre-operatively embolize it. Pre-operatively, you embolize. We have lots of embolizing agent. The commonly used one are gel foam. This is where your radiologists come. My radiologist's job is I'm going to do an MR angiography. In the MR angiography, the radiologist will say which is the feeder vessel. For example, let's assume that this tumor gets maximum blood supply from spinopalatine artery. So what I'm going to do is, I'm going to embolize the branch of spinopalatine artery which feeds this tumor. Once that is done, the entire tumor will lose its blood supply. The entire tumor might shrink and it will become smaller, which will be easier for me to remove, right? So embolization of the feeder vessel. The feeder vessel will be told by your MR. MR stands for magnetic resonance angiogram or angiography. MR angiography will tell me which vessel is involved. I'll embolize the vessel. It will shrink. After that, the tumor will shrink. Once it shrinks, you can remove surgically. You can have a surgical removal. Okay, that's possible. And that's how we treat it. Fine. When it is too extensive, it can enter into the brain, it can enter into the cranium, then the prognosis is going to drop a lot. That's about juvenile nasopharyngeal angiofibroma or just nasopharyngeal angiofibroma. We're done with one tumor. We saw three main one and your nasopharyngeal carcinoma as well, right? The second one, what you're going to see is your sinonasal papilloma. The sinonasal papilloma may not come in an exam for you. One, it is rare, may come in the ENT exam, but not in a pathology exam. These, whatever topics we are reading, nasopharyngeal carcinoma can be asked and JNA can be asked. Again, they'll be asked more in ENT than in pathology. If in pathology, they'll ask you in Viva. So sinonasal papilloma, it's a papilloma. Again, it's a benign tumor. Whenever you have any term, divide the term, you will learn a lot. Papilloma, it's a benign tumor. So what will be the microscopy? That's also in the name. Papilloma, papillary projection. That's what I'm going to see in the microscopy, right? It's a benign neoplasm of the respiratory mucosa. It's a benign neoplasm which arises from my respiratory lining. The respiratory lining can be from your nasal cavity, can be from your paranasal sinuses. I'll have the respiratory lining there as well, right? From anywhere it can come. The sinonasal papilloma, we are going to divide them into three different types. Okay. It's a papilloma. A papilloma can grow outside. Exophytic. A papilloma can be growing inside the epithelial membrane. I'm going to call it inverted or endophytic. And one more variant based on my microscopy. I can have an exophytic papilloma. So exophytic papilloma, if this is my lining epithelium, the black one is my lining epithelium, my exophytic papilloma is going to look like this. Simply a proliferative lesion, that's all. I have something called as an endophytic papilloma, or otherwise called as an inverted papilloma. As the name says, it's inverted. Again, if black is my lining epithelium, it's going to be the reverse. It's going to go inside to it. That's inverted papilloma. The third type is called as an oncositic. Okay, oncositic papilloma. Again, this is a terminology. When you have anything oncositic, wherever you see oncocyte means it's a cell with abundant pink cytoplasm, right? So microscopy of this both will have papillae only. I'm just writing MX for microscopy. I'll have a papillae, finger-like projection with a central fibrovascular core lined by the nucleus. Here it will protrude to the top because it's exophytic. Here also I'm going to have papillae, but the only difference is I'll have it inverted. It'll be inverted. Same cells with a central fibrovascular core. Oncositic papilloma or oncositic variant of it, how it's going to look is, I'll have the same papillae. The only difference here is the papillae will be lined by cells which will have an abundant pink cytoplasm. That's why it's called as an oncositic. Oncositic means it will have any cell which is called as an oncocyte will have an abundant pink cytoplasm. Have you heard of a cell called as Herthal cell? Anytime have you heard of a cell called as an Herthal cell? So oncocyte will have an abundant pink cytoplasm. Herthal cell you will see in a disease called as Hashimoto's thyroiditis. Herthal cell is also an oncocyte, right? Herthal cell is also an oncocyte. That also will have abundant pink cytoplasm. When Dr. Ilan takes salivary gland tumor, you will have a tumor called as Wharton's tumor. That also will have oncocyte. So whenever you read the term oncocyte, you should imagine that the cells will have an abundant pink cytoplasm. See, these are just terminologies. Our main goal is to understand the terminologies so that Your main goal now is to pass your MBBS exam, right? Just with the name, you can write 5-10 lines easily. If you're smart enough, just the name is enough for you to write. Anatomy and biochemistry and physiology, you must have done that only. I'm just going to aggravate or give ego boost to your existing intellectuality of writing stories. That's all required for us. Fine. It's a papilloma. It's a benign tumor. It's also a bit locally aggressive, right? Because the nose is a very enclosed cavity. It's a benign tumor. This is also a locally aggressive tumor. It can extend into your paranasal sinus. From the paranasal sinus, it can go to my orbit. It can go to the cranial vault as well. Fine. I have a papilloma in the Sino, in the maxillary sinus. Let's assume I'm having a papilloma in the maxillary sinus. Maxillary sinus surgeries are done via endoscopy. Most of them are done via endoscopy. I don't open the nose and do a surgery. It's done via endoscopy. When it's inside the maxillary sinuses, I'm going to put a scope inside and try to remove everything. Sometimes I may miss it. If I miss, if not completely excised, treatment is going to be surgery. If not completely excised, it may recover. Okay, it may recur. Fine. I didn't tell about the pathogenesis. Most of the sinonasal papilloma will have HPV DNA, same HPV related only, 6 and 11. It's a benign tumor, not a carcinoma. So the 6 and 11, your episomal form of integrated HPV will be seen here. So pathogenesis will be HPV 6 and 11 related because in benign lesion, right? Same E6, E7, all the other findings will look the same. Right? That's about sinonasal papilloma. That's my second tumor. The third tumor which can come in my nasopharynx is olfactory neuroblastoma, nose and nasopharynx together. Right? The third one is your olfactory neuroblastoma. So how an olfactory neuroblastoma will look, and the presentation and your findings. See, one more information I'm going to give to you. I'm just going to give generalized information which you can use for anywhere. Whenever a tumor ends with blastoma, neuroblastoma, nephroblastoma, any blastoma tumors, the age group will be seen in children. Sometimes can be seen in adults as well. Olfactory neuroblastoma is bimodal distribution. In general, whenever it's blastoma, it's going to be seen in children. Retinoblastoma, seen in children. Nephroblastoma, other name of Wilms tumor, seen in children. Microscopy of all the blastomas are small round blue cell tumors. They look small, round and blue. That's how it looks. Every blastoma will look small, round and blue, right? These two, you can write for any blastomas. Here, age of the blastoma, here it's going to be bimodal distribution. But commonly, every blastoma will be seen in younger age group, first or second decade. But here alone, it's going to be bimodal distribution, okay? The origin of neuroblastoma, olfactory neuroblastoma, is a neuroectodermal cells of the olfactory mucosa. Right? They originate from the neuroectodermal cells or the olfactory cells seen in the nasal cavity, seen in the nasal mucosa. Fine.
Hello.
Okay. Neuroblastomas, as I said, microscopy will have small round blue cells. It'll have small round blue cells. Most of the neuroblastomas, most of the blastomas as such will have a bit of high mitosis. They are a little bit fast growing tumors. They have a bit of high mitosis. Fine. You'll have a high mitotic rate. In other words, they are fastly growing neoplasm, fast spreading neoplasm. Fast growing tumors. Okay. When a tumor grows faster, good for us or bad for us? When a tumor grows faster, good for us or bad for us? Just a general term. Tell anything, you'll be 50% correct anyway. A tumor grows faster, bad for us, correct. Why bad? Because it's going to spread faster, right? That's why I'm sure you must have said bad. But at the same time, when tumor grows faster, I would like to say it's good for us. Because if you have come across cancer chemotherapy chapter in pharmacology, chemotherapy drugs act on resting cell or dividing cell? Chemotherapy drugs act on resting cell or dividing cell, or radiotherapy acts on resting cell or dividing cell. Only a dividing cell, right? Radiation also affects a dividing cell. Chemo also affects a dividing cell. So when I'm saying a blastoma, a neuroblastoma, I'm saying that 50% of the cells in this tumor, I'm just giving an example, 50% of cells in this tumor are dividing. So when I give chemotherapy, am I right in saying that all 50% of them will die? Yes, right? So I'll have a good response to radiation and I'll have a good response to chemo. As you said, it's bad because it's going to spread faster. So my only thing is, when I have an early diagnosis, yes, I'll have a very, very good response, right? They have a fast growing tumor. So my goal here is early diagnosis. They are missed normally because not much of a symptom. It will not tend to miss. It will be a symptom. But how many of us go to doctor for nasal obstruction? We use the Vicks and we go away, right? Nasal obstruction or maximum epistaxis. It must have been big. But what is high mitotic treatment is surgery. If it is limited, one surgery. If it has extended elsewhere, radio and chemotherapy will help. Radiotherapy and chemotherapy will help. See, whatever I said that fast growing tumor will be amenable to chemotherapy is true for every tumor. You can extrapolate for any tumor because of the cell division. You guys only said that it acts on a dividing cell because cell division, they have a very, very good response. The survival rates can be even like 75 to 90% can have survival rates for 5 years. Right? They have a very good response because of the cell division. So I know everything. I know small round blue cell tumor. Lymphoma also will be small round blue cell. Ewing sarcoma also will be small round blue cells. So I need markers. I'm just writing the markers last because sometimes it's not required for as much. For an undergraduate, not much required. We're going to have markers for this neuroblastoma marker. I can use it for adrenal neuroblastoma as well, or any carcinoid tumor. In carcinoid tumor, small cell carcinoma of lung, what were the markers we saw? We saw 2 markers for small cell carcinoma of lung. That's also neuroendocrine. Perfect, same markers. You guys already know everything. Right, synaptophysin, chromogranin. I'm going to use the same markers. Here, IHC is same. Synaptophysin, chromogranin. Right. You know 2 of them. I'm NSC. Chromogranin, CD56 more used, and also NSC. Right? These are the markers of any neuroendocrine tumor. Neuroblastoma is also a neuroendocrine tumor. I'm going to use the same markers here. Fine. That's about your third tumor in the nasopharynx. The last biggest one is your nasopharyngeal carcinoma. Nasopharyngeal carcinoma. Already, nasopharyngeal carcinoma is an squamous cell carcinoma. If it's a squamous cell carcinoma, for carcinoma, you can write 4 points. The 4 features of dysplasia, high NC ratio, pleomorphism, and all those this. Microscopy of squamous cell carcinoma, you can write is a keratin pearl formation. IHC for squamous cell carcinoma, you already know, P40, P63. Write that. Your pathology teacher can never say it is wrong. It will be correct only. You can fill already half page. Next half page, put a square mark and draw a keratin pearl. Keratin is acellular, so it looks like this. That's how a keratin pearl look. 1 page is done. Without knowing anything, we are done with 1 page. So we'll know something and we'll make it 2 pages. That's our ultimate goal, right? Nasopharyngeal carcinoma, one important thing regarding nasopharyngeal carcinomas, geographic distribution. Nasopharyngeal carcinomas are common in few parts of the world. One place where it's common is Africa, because almost every nasopharyngeal carcinoma is associated with EBV infection. Take this also, whenever it's a viral induced disease, it will be more common in Africa. Right? China also, I'll come to it. Any viral related lymphomas, more common in Africa. because Africa is a birthplace for every virus, right? Anything comes, it comes from Africa, and except the last virus, which came from China, which is destroying all of us, right? So I'm going to have a geographic distribution. That's very common in nasopharyngeal carcinomas. Very common in Africa. Because of the virus, it's EBV related, Epstein-Barr virus related. That's why it's common in Africa. Some of you said it's also very, very common in China. Fine. China is going to be common. It's also common in China. Because of wood industry and more of tiny little specks of wood used in China, and diet will have high nitrosamines. Okay, that's one reason China is more common. It's related to wood dusts. It's common, and also nitrosamines in the diet. Okay, nitrosamines will have in all the fermented foods. The salt you'll have, right? Salted fish, sardines, all those will have the high rich in nitrosamine. Or in other words, the Ajinomoto which we use, that also will have a little bit of nitrosamine. That's more common in China. In their food habit is very, very common. So it'll have, that can cause gastric carcinoma as well. Fine. So you'll have nitrosamines in food. Apart from that, we already know smoking. Smoking will be linked to anything which is there in my respiratory tract, right? That is not geographic. Smoking is a universal language. Right? That's not because of geography. Everywhere, any smoker is predisposed to a cancer. Fine. So what we are going to read in pathogenesis, chemical carcinogen, I'm not into depth of it. I'm more concerned about my EBV. Because EBV is one which I can target, maybe possibly treat in future. So how does EBV cause a cancer? How does EBV cause a neoplasm? So EBV, generally what you must have read is EBV enters lymphoid tissue, right? EBV enters lymphoid tissue. That's what we must have read. EBV also is like a HPV protein, HPV virus. So EBV also is going to have few viral particles. Those viral particles are the one which are going to affect me, which is going to relate into the cancer, right? Perfect. I'll have LMP and EBNA2, Ebna and LMP. So EBV will have two viral particles. LMP stands for latent membrane protein. That's a viral particle. It's same like your E6 and E7 particles of HPV. Latent membrane protein, we have two of them, LMP1 and LMP2. LMP1 is more important for me, LMP2 as well. And other one called as Ebna. EBV associated nucleic acid. EBV for EB, and NA is for nucleic acid. It's just EBV nucleic acid. Right? Ebna1. So in LMP, I have LMP1 as well as LMP2. So these are the guys which are going to help in the Oncositic, or said it's going to act nuclear factor K beta. Right? Nuclear factor K beta is a transcription pathway. It activates will be majority by LMP. LMP2 is going to activate phosphoinositol triphosphate kinase pathway. Again, it's a signal transduction protein, more cell division. It's going to help in more cell division. Okay. What does Ebna do? So what does Ebna do is, so Ebna is a nucleic acid. It's going to interfere with my DNA repair mechanism. So when an EBV comes into my cell, integrates into my DNA, my body knows that there's some abnormality in my DNA. So by nature responses to correct the DNA damage. Same by examples of your nucleotide excision repair, base excision repair, mismatch repair mechanism. My body will correct it. So what Ebna does is it's going to reduce the capacity of DNA repair. How they are going to reduce capacity of DNA repair is by inhibiting P53. P53 is the guardian angel, right? P53 is the person who's going to say, okay, this guy has a problem in my DNA. I'm going to stop the cell cycle and recruit all the DNA repair mechanisms. So this eBNA is going to stop P53. In that, indirectly is going to help me or protect me from help me to accumulate more DNA damage, which results in more cancer, right? That's in general about the pathogenesis of an EBV in cancer, in carcinoma. In lymphoma, it's totally different. Same molecules only, but in a different way you will read about when you go to lymphoma, right? So now my microscopy, I have to know it's squamous cell carcinoma only. Here also I have non-keratinizing variant, keratinizing variant. And one more variant we have in nasopharyngeal carcinoma called as basiloid squamous, right? Oid means what? What does oid mean? Like, perfect. Basiloid means basal-like. Where do you see basal? The basal epithelium. Epidermis has 5 layers, right? Stratum basal. So it looks like basal layer. So it's called basiloid. That's all. So basal layer, if you remembered your skin, basal layer will be blue in color. So basiloid squamous cell carcinomas will be more blue in color. I may not have keratin because basal layer doesn't produce keratin. I will not have keratin pearls. With one word, we can extend a lot, right? So basiloid squamous cell carcinoma means they look like basal cells or the basal layer, stratum basal. When they look like basal layer, there'll be no keratin pearl because basal layer cannot produce it. And basal layer will be tiny and blue, right? They're going to be bluish in color. Squamous cell carcinoma generally will be pink in color because of more keratin production, fine? Okay. So I need to know that I'm going to have an EBV infection here. I need to prove that there's an EBV infection here. I don't have any microscopic evidence of EBV, but for EBV, I have lots of IHC. You have IHC for the virus particle as such. You have something called as Eber-ish, in situ hybridization. In situ hybridization is much, much better than IHC. In situ hybridization called as Eber-ish. ISH stands for in situ hybridization. Fine. That's much better. If not available, go for an EBV DNA analysis. That will obviously be the best. But generally, it's based on economy. If the patient is a little bit affordable, I'll do an EBV IHC. More affordable, either Eberish or an EBV DNA, right? That's about your pathogenesis, microscopy, and etiology of nasopharyngeal carcinomas. And obviously, you need to know about the symptoms. Nasal cell carcinoma, like any other nasal tumor, is going to present with nasal obstruction epistaxis. It's a tumor, so it can be more invasive. It can cause neural damage as well. Nasopharyngeal carcinomas can spread to any of the cranial nerves and can damage a little bit of cranial nerves here and there. When you go to ENT, you will see a whole lot of cranial nerve involvement in nasopharyngeal carcinomas, and there are a few symptoms which are related to that as well. But major presentation is going to be nasal obstruction and epistaxis, and can metastasize to lymph node as well. Fine. That's about nasopharyngeal carcinoma. Sorry. So what we have done till now is we have done about squamous cell carcinoma of head and neck, the divisions of it. We have done about nasopharyngeal tumor. We saw about papillomas. We saw about juvenile nasopharyngeal angiofibromas, and we saw about your neuroblastoma, and also we saw about the nasopharyngeal carcinomas. Fine. Larynx. I'm not going into depth of larynx because it's the same thing. It's same HPV-related tumors, same HPV 6 and 7 for benign laryngeal papillomas, and dysplasia and hyperplasia, dysplasia, and carcinoma sequence for a malignant HPV subtype. Laryngeal tumors, based on the location in the larynx, the glottis, supraglottis, or subglottis, the symptom will vary. And treatment is going to be the same, microscopy is going to be the same. So I'm not going into depth of laryngeal tumors. It's going to be the same, right? So what is left for us is, we're going to read about paragangliomas. Since I'm reading about paraganglioma, I'm just going to incorporate one more thing also. I'm going to incorporate pheochromocytomas as well. Because both are same. Paragangliomas are also called as an extra-adrenal pheochromocytoma. It looks the same, it behaves the same. So why not to read some things differently, right? We'll read both of them together. So what is a paraganglioma and what is a pheochromocytoma? How do they look? How do I diagnose them? And what's the treatment if possible? And what will be the microscopic appearance? Pheochromocytoma arises from your adrenal medulla. Paraganglioma can arise from any sympathetic ganglia. Adrenal medulla is supposed to be the largest sympathetic ganglia, right? Fine, it can arise from any of the sympathetic ganglia. I'm going to call it paraganglioma. So the origin of these are the ganglia. If it's sympathetic ganglia. If it's going to arise from the adrenal medulla, it's the largest sympathetic ganglia. I'm going to call it pheochromocytoma. If it arises from any other sympathetic ganglia, in the head and neck, I'm going to use the term paraganglioma. I'm writing HNN for head and neck. I'm going to call it paraganglioma. So symptom more or less will be the same. Microscopy more or less will be the same. Presentation more or less will be the same. I'll have different terms, that's all. Head and neck, I can have carotid body paraganglioma. I can have vagus nerve paraganglioma. I can have laryngeal paraganglioma. If it involves the carotid body and aortic body, I can call them chemoductomas. Because you know that in your physiology, they do have chemoreceptors. So I have different terminologies, different namings, that's all. The name might change, but behavior, microscopy, everything will be the same. I can call it carotid body paraganglioma. It can originate from the carotid body. It can originate from the vagus. I'm going to call it vagal paraganglioma. Or it can originate from laryngeal nerves. I'll call it laryngeal paraganglioma. I am reserving the term chemoductomas for paragangliomas arising from your aortic as well as your carotid body. It is arising from aortic and carotid body. I'm going to use the term chemoductoma because they have the chemoreceptors, that's all. Fine. Okay. So I can have symptom. I may not have symptom. These are going to produce your adrenaline and noradrenaline. So hypertension is very common in most of them. They produce catecholamines. So hypertension is a common symptom. May be there, may not be there. Again, it depends on the location. It depends on what the organ is going to secrete. Your clinical symptom is going to vary. So clinical symptom, I'll just write clinical symptom based on the organ it's going to involve. If it's going to involve adrenal gland, most of them will secrete. You'll have a triad of hypertension. In other words, most of them is going to have the same symptom which you all guys had when you sat in your university exam anatomy viva with a very strict examiner. Palpitation, sweating, flushed appearance, tremors, and hypertension. Same thing. Catecholamine excess, right? Adrenal gland will have the same thing. Hypertension, headache, palpitation, sweating, same. Flushed appearance, everything. Because of increase in catecholamines. Because the normal function of adrenal medulla is to produce catecholamines, they are also going to produce the same thing, catecholamines. So carotid body. The carotid body paraganglioma may not produce catecholamines. They rarely produce catecholamines. So how do they manifest and how I'm going to know it? They are very slow growing mass, a very painless mass. Since the location is close to my foot pipe and my windpipe, it may cause dysphagia. Since it's near my carotid sinus, it can impinge on the carotid sinus and can cause bradycardia and syncope because carotid sinus will take it as an impulse and will act in response to it, right? If it's a carotid body paraganglioma, they're going to rarely produce catecholamines. So the above symptoms of adrenal, I will not see them. Right? They rarely produce catecholamines. So my symptom is going to be based on the location. They are painless mass, so I will not have pain. Most of the tumors are painless. So I may have symptoms of dysphagia. It can impinge on the esophagus, produce dysphagia. It can impinge on my carotid sinus and produce bradycardia and syncope. It's just a pressure. It's just a symptom. It's because of the carotid sinus involvement. I can also call it as carotid sinus syndrome, right? Because of the involvement of carotid sinus. Carotid body paraganglioma is also a part of a triad. This can be asked in the Viva especially, or just if you want to score extra point, do write this triad. We have a triad called as Carnes Triad. Have you heard of this triad? You'll read about this triad when you come to GIT as well. Carnes Triad, yeah, perfect. Just, okay, lab, just, sorry, excuse me. Perfect. Just pulmonary chondroma and extraadrenal paraganglioma can be anywhere, commonly in carotid region. Lab, just gastrointestinal stromal tumor, lab, pulmonary chondroma or hamartoma or chordoma, and you'll have extraadrenal paraganglioma. Okay. There's a triad called as Carnes Triad. I can have the paraganglioma in the jugulotympanic region as well. When it's the jugulotympanic region, the paraganglioma will present into the middle ear. Will present as a middle ear polyp because it's the lower portion of the middle ear will have the jugulotympanic boundary. It can protrude into the middle ear. It can present as an glomus tympanicum. It can be in the jugular bulb. It can cause deafness or hearing loss, right? Those will be the symptoms of an jugulotympanic paraganglioma. When the jugulotympanic region can have paraganglioma in that region as well. So symptom will be, they'll present as an, it's called as a glomus tumor, glomus tympanicum. When I have that, what you will see is, you will see an red bulge from the base of middle ear. That base of middle ear bulge can cause hearing loss, hearing defects. It will not be deafness, it will be hearing defects. Because I'm having some bulge in the middle ear, it's going to alter the problem conduction of the middle ear. I may have a hearing defect. Okay. Then laryngeal paraganglioma. Like any other laryngeal tumor, whenever you have disturbance in the laryngeal region, the first and the foremost finding is hoarseness. The voice change will be there, and sometimes dysphagia as well. Okay, yeah, dysphagia or hoarseness of voice. Fine. So how it look in microscopy? I'm going to say microscopic appearance, which is going to be similar for pheochromocytoma as well as paraganglioma. This tumor will also have a nesting pattern. In lung, we saw one tumor with nesting pattern. What is the tumor? In lung, we saw a tumor with nesting pattern, and we call it carcinoid, right? Carcinoid tumors have nesting pattern. NET, neuroendocrine, carcinoid. Here, I'm going to give a special name for the nesting pattern. We're going to call it Zellballen, right? It's the same nesting pattern only. The term is different, called as Zellballen. It's called a Zellballen pattern or a nesting pattern only. The reason why it's called Zellballen is it was discovered in German. It's a type of dance in Germany where they will be in rounds. In a group, they're going to dance. That's why it looks like that. So it's called a Zellballen pattern. Same nesting pattern only. The uniqueness of this nesting pattern is you'll have nests of tumor cells. You'll have nests of tumor cells here. The tumor cells is going to be small, round, and blue, like any other neuroendocrine cell. And the chromatin will have the stipple chromatin, like any other neuroendocrine cell. The salt and pepper chromatin, everything is said, is implied. One more important thing is you'll have cells in my septa as well. I'm going to have cells in the septa. I'm going to call these cells supporting cells or sustentacular cells. I'll have cells in the septa, plus I'll have tumors. The cells in the septa are not the tumor cells. The tumor cells are inside. These are the tumor cells. The tumor cells will be small, round blue, like any other small round blue cell tumor. Like any other neuroendocrine tumor, you'll have the same salt and pepper chromatin. The reason for salt and pepper chromatin is simple. I'm sure we saw that in carcinoid as well. Salt and pepper, because it's a mixture of euchromatin and heterochromatin, because these cells produce catecholamines. So I need to have euchromatin that produces catecholamines, right? So we'll have dark and light salt and pepper appearance. In addition to that, I'll have supporting cells. Supporting cells or your sustentacular cells. If you cannot say sustentacular, completely fine. Say supporting cells is more than enough. Yeah, both supporting cells or sustentacular cells. So if I know the microscopy, the next thing which I'm going to look at is obviously the IHC. I have tumor cells, which is of neuroendocrine origin. So I'm sure you will know the IHC. What are the IHC for neuroendocrine origin tumor? Just now we saw same shit, right? Chromogranin, synaptophysin, CD56, NSC. The tumor cells will be same. IHC for tumor cells will be same. Synaptophysin, chromogranin, CD56, and NSC. Neuron-specific enolase, NSC. In your hematology, you must have read about one more NSC. That's totally a different NSC. So I have sustentacular cells as well. Those are not tumor cells. Those are not neuroendocrine cells. So I'm going to have a different marker. The IHC for sustentacular cells is S100. That's IHC for sustentacular cells. Okay. Treatment is surgical excision. They can be benign as well as malignant. If malignant, they may spread and they may recur. Fine. Treatment is going to be surgical excision. During surgical excision, especially for pheochromocytoma, the BP is going to rise a lot. During that time, in your pharmacology, you must have read that I'm going to give a drug. Intraoperatively, to operate pheochromocytoma, you need a specific antihypertensive. That's a viva question in your pharmacology as well. What's the drug? See, I don't know the drug. If you say that, you have to know the drug. I am not sure about it. It's an important question. That's all I know. Please go back and read about the drug. Okay. That drug should be given and then only should be operated so that BP fluctuation and rise will not be there. Right? That's about your paragangliomas. Okay. So we are done for the day. We have seen about Hedonic squamous cell carcinomas. We saw about nasopharyngeal tumors and we saw about paragangliomas. Laryngeal tumors are same like nasopharyngeal carcinomas, nothing much different. The only difference is going to be presentation because of the hoarseness of voice, because of the location. And treatment, you will read a lot. Treatment is based on staging. You'll read a lot about them in ENT. Fine. If you have any doubts, do let me know. No doubts? Okay, none at all. So it goes without saying, either you've understood everything or you're not understood anything. I hope it's the first one again. Okay. Anirudh, if there are no doubts, can we call it a day? Thank you, Shravani. Thank you. If you have any doubts in pathology while understanding, anytime you can text me. I'm there on Facebook, Instagram, as well as Telegram. Whichever is comfortable to you, you can text me. I do reply. Most of the time I do reply. Fine. If you come to Bangalore, you're most welcome to visit our lab. I'll show you many things about microscopy as well. I'll show you real life how pathology is going to have an impact on cancers. Fine. Till then, bye-bye. See you. Thank you. Bye. Natalismab, I like your name. Bye-bye.